My name is Dr. Shamoon, and I'm going to be presenting Beyond the Case, a case presentation on interstitial lung disease in the setting of dermatomyositis. Dermatomyositis is a rare multi-system inflammatory disorder that can present with cutaneous and myopathic manifestations. It is believed that the prevalence of this condition is 13 per 100,000, with the annual incidence of all subtypes being around 1.1 per 100,000. There are several manifestations of the disease, one of which include interstitial lung disease, which can present with pneumomyositis and/or subcutaneous emphysema, both of which have been reported as complications since the 1990s. ILD is a relatively common complication of dermatomyositis, occurring at a rate of 30 to 40%. The prevalence of ILD among cases of DM can vary from 20 to 80%. Spontaneous pneumocystis is a rare but serious complication of DM that is associated with high morbidity and mortality rate, which, while not fully understood, it is believed that pneumocystis occurs as a result of multiple proposed mechanisms that include alveolar rupture, subpleural blood rupture, and the result of corticosteroid use, and vasculopathy. Instances of pneumocystis have been observed in dermatomyositis patients without known ILD, suggesting that another contributing factor can be disruption of the surrounding vasculature of the bronchial mucosal barrier, leading to subpleural infarctions. So we presented a case of a 30-year-old male with a past medical history of significant for atrial fibrillation and hypothyroidism, presenting with concerns over neck swelling with an associated voice change. He was recently diagnosed with dermatomyositis after noticing skin changes that evolved over the course of 2 months. He stated that a number of months prior to admission, he was discovered during routine labs an elevated amount of red blood cells, for which he was referred to hematology. Around the same time, he began experiencing fatigue with progressive muscle weakness, followed by skin changes. Further testing for antibodies done by his hematologist discovered the presence of autoantibodies against melanoma differentiation associated protein 5. At this point, he began involving with rheumatology and dermatology and performed a skin biopsy with the formal diagnosis of anti-MDA5 associated DM being made. The patient stated that prior to arrival, he was experiencing shortness of breath with voice changes that occurred over the course of 3 weeks. The night before his hospitalization, he noticed his right neck was swollen, and when he woke up, he had difficulty breathing and swallowing. The patient went to his local ED, where CT neck showed evidence of pneumomyositis and neck emphysema. On arrival, the patient was noted to have swelling of the neck, most notable in the right neck with associated crepitus, followed up with imaging of the chest performed, which shows an extent of pneumomyositis. The patient was stable with normal vitals. Throughout the hospitalization, he remained on room air with oxygen saturations around the 90s. Pertinent exam findings on admission include multiple skin changes, lesions around the eyes, extensor surfaces of his arms, hands, and feet. The patient demonstrated across the eyelids as well. So eventually he did get better with on room air, and it resolved spontaneously. Dermatomyositis can lead to interstitial lung disease through a complex of interaction of immune-mediated mechanisms resulting in inflammation and fibrosis of the lung tissue. The subtype presented in this case of anti-MDA5 antibodies may also contribute to the pathogenesis of ILD in various ways. Understanding the pathophys of anti-MDA5 in dermatomyositis helps in recognizing the clinical manifestations and guiding appropriate treatment strategies, aiming to control inflammation and prevent progression of ILD. The pathophys of anti-MDA5 DM involves immune dysregulation, chronic activation of the interferon pathway, systemic inflammation, and endothelial cell damage and repair mechanisms. These processes collectively contribute to the characteristics of skin manifestation and the rapid progression of interstitial lung disease. So the patient presented with these classical symptoms coupled with progressive respiratory distress highlights the importance of recognizing the potential pulmonary complications early in the disease course. Patients must be educated on warning signs. It is also important to be educated on the disease processes and proper multidisciplinary approach. In any situation, it is essential to determine the patient's socioeconomic challenges. This patient was treated with high-dose steroids and also immune suppressive therapies and shows significant improvement as well. This highlights the importance of aggressive and early treatment to control the disease activity and prevent severe complications such as rapidly progressing ILD.